A 62-year-old man comes to the clinic because of progressive weakness and fatigue for several months. He also reports nausea and recurrent headaches during this time. The patient says that climbing stairs is extremely difficult for the first few steps, but becomes easier as I keep going. He quit smoking 2 years ago after a 40-pack year history. Vital signs are within normal limits. Laboratory studies reveal sodium at 116 milliequivalents per liter, normal range 136 to 146. Potassium 4.5 milliequivalents per liter, normal range 3.5 to 5. Bicarb 25 milliequivalents per liter, normal range 22 to 28. Which of the following most likely explains this patient's feelings of weakness? Choice A, antibodies against voltage-gated calcium channels. Choice B, antibodies against acetylcholine receptors. Choice C, antibodies against chloride channels. Choice D, antibodies against myelin. Choice E, proteolysis of synaptobrevin. Or choice F, destruction of acetylcholine esterase. I'll wait 5 seconds and then answer your question. So this should not be too hard of a question. This is a very textbook example of small cell lung cancer. You have the long-term history of smoking as his risk factor. I mean, obviously he quit 2 years ago, but he still has that 40-pack year history, and that is still going to affect him. And of course, this question is all about the paraneoplastic syndromes of small cell lung cancer, which in this case he has lambert-eaton syndrome, which is shown through his progressive weakness, and how he talks about it. It's hard to climb stairs for the first few steps, but becomes easier as I keep going. This was just my way of describing a muscle weakness that improves with use, which is what lambert-eaton is like. You would contrast that with myasthenia gravis, which gets worse with use. And in addition, like these feelings of fatigue and headaches, nausea, as well as this hyponatremia, that was just me working SIADH into this question, which is another paraneoplastic syndrome you need to know for small cell lung cancer. The other one is Cushing syndrome, because small cell lung cancer can release ACTH. I didn't work that into the question, but you do need to know that. But anyway, since he has lambert-eaton, we do know that lambert-eaton is caused by choice A, antibodies against voltage-gated calcium channels. Now I want to go ahead and jump to choice B real quick, antibodies against acetylcholine receptors, because this is myasthenia gravis, which they really like making you differentiate this from. Myasthenia gravis targets nicotinic acetylcholine receptors, or in rare cases it can target MuSK, muscle-specific receptor tyrosine kinase, which causes a muscle weakness that I mentioned, becomes more severe with use rather than becoming better with use. And the classic association they like making with myasthenia gravis is thymoma. So instead of you saw a patient where they had a mediastinal mass or something, and they have muscle weakness where they start exercising and they get tired really quickly, that would be myasthenia gravis. Now, some people have a lot of trouble remembering the difference between these two. Let me try to explain it in the way I understand it, okay? This isn't necessarily quote-unquote scientifically accurate, but it's just a nice way of thinking about it. Lambert-Eaton, as mentioned, attacks calcium channels that are presynaptic. Myasthenia gravis targets the acetylcholine receptors that are postsynaptic. So I like to think of it like this. If I have less presynaptic calcium channels, well, I can just move more and more and just keep stimulating that junction until I have a bunch of acetylcholine in there. And after that, I'm home free, right? Because the problem is with the presynaptic channels. So if I go out of my way to stimulate them over and over until I just have a high concentration of acetylcholine in the neuromuscular junction anyway, then I don't have any problems. However, with myasthenia gravis, I have antibodies against the acetylcholine receptors, which is kind of the final receptor in the NMJ. So it doesn't matter how much I stimulate acetylcholine to be released into the cleft. I don't have the receptors to actually receive them. And in fact, if I try to move around more, I'm just going to get tired faster because I don't have enough receptors to keep up with that. Anyway, that's just how I think of it, so you can take it or leave it. Let's just move on. Choice C, antibodies against chloride channels. This is a nonsense distractor for the most part. There is a rare condition known as myotonia congenita that does involve chloride channels, but this is totally irrelevant for USMLE, so don't bother thinking about it. On USMLE, if they want you to be thinking about chloride channels, it's almost always going to be talking about cystic fibrosis, which is unrelated here. but I'll just bring it up anyway just because that's the thing almost everyone will think of with chloride channels on USMLE. Choice D, antibodies against myelin. This is likely describing Guillain-Barré, which is an autoimmune polyneuropathy that causes an ascending paralysis. So obviously you have autoimmunity against your myelin, and that will just damage your nerves essentially. Usually the association with Guillain-Barré is post-infection. Campylobacter jejuni is classic, but it can also happen with mycoplasma, HIV, EBV, various other infections. Doesn't really fit here. Choice E, proteolysis of synaptobrevin. This is describing both botulism and tetanus. Obviously, botulism is the one more relevant to this question in the sense that it also causes muscle weakness. Both of them involve cleavage of snare proteins, but sometimes USMLE is really mean and they'll just write it out as synaptobrevin. They will have opposite effects because in botulism, you prevent the release of stimulatory neurosignals, and in tetanus, you prevent the release of inhibitory signals. So that's why in botulism you have flaccid paralysis, floppy baby, and all that. And tetanus, you'd have, well, tetany. Obviously, a lot we can talk about with both these things. I mean, botulism, you know, they like making the association with like canned foods, you know, honey. Tetanus, you know, they like talking about, you know, rusty nails and that sort of thing. That's really buzzy. And obviously, you need to know that these are toxins released by Clostridium botulinum or Clostridium tetani. As far as this patient goes, obviously, he doesn't really have a history of eating anything in particular. At least they don't tell us that. He didn't cut himself on anything, and it wouldn't fit anyway. Choice F, destruction of acetylcholinesterase. This is mostly describing organophosphate poisoning. This would cause various muscarinic symptoms, so he would be having secretions out of everywhere. He would have meiosis, bradycardia. Doesn't remotely fit, wrong answer. So just bringing it back, you need to know that lambert-eaton is associated with small cell lung cancer. You also need to know that small cell lung cancer can cause SIADH and Cushing syndrome from its paraneoplastic syndromes. Know that lambert-eaton is antibodies against presynaptic voltage-gated calcium channels, and be able to differentiate that from myasthenia gravis, which you tend to see more in thymomas, and it is antibodies against acetylcholine receptors postsynaptically. And just as a final note, the NBME question that I based this off of, they had muscarinic receptor as one of the answer choices, and in the official explanation that the NBME gave, they claimed that muscarinic receptor blockage has to do with myasthenia gravis. Now, myasthenia gravis is classically described as nicotinic receptors, not muscarinic receptors, so I think the NBME is wrong. But I bring it up because it's the NBME, and sometimes you can't argue against the NBME. But it also doesn't matter that much because on the NBME is also a wrong answer anyway. But I'm just bringing it up for completeness sake. Anyway, I hope you enjoyed this video and I hope it was helpful. I'll see you in the next one.